So hello and welcome to this update around the National Early Inflammatory Arthritis Audit project. I'm James Galloway. I'm a rheumatologist based in King's College Hospital in South London. I'm also joined today by Dr Ed Alveyn, who is a rheumatologist, works in the same trust as me. We both work for the National Early Arthritis Audit project. I'm the analytics lead and Ed is the audit fellow. The purpose of this talk over the next sort of 10 or 15 minutes is to give you a bit of an update around what is changing in the audit, and then we're going to have a look at some of the questions that have been asked around the changes. I'm going to start by saying that this presentation is aimed at both clinicians who are taking part in the audit, but really importantly also audit administrators who are helping us with this project. So I'll very aware that the early arthritis audit is evolving. It may, in fact, in not too far in the future, get a new name, but it is very definitely a quality improvement project. And whilst I know that if you talk to clinicians working in hospitals and you say, what is your key agenda item this week, this month, they may talk about some new research there, some new therapy that's available. But actually, things like quality improvement and audit sometimes fall down the list of importance within trusts. I'm going to try and convince you, and for those of you that are clinical, those of you that are working in audit departments, I'm going to try and convince you that actually audit is essential to what we do. It is the bread and butter of monitoring and making sure the care we deliver is really impactful and of a standard that we can be proud of. Because we know that across the NHS, our goal is always to provide the best care for the patients with the resources that are available to us. That isn't in doubt, but what is very true is that we don't all have access to the same resources. If you look across the country, there is substantial variation in the availability of consultants, of specialist nurses, of pharmacists, of allied health professionals to deliver the care needed to provide a high quality rheumatology service. We also know it's not just about resource allocation that varies around the country, but it's also around the care that is provided within a department. Audit is a mechanism by which we can capture information on these attributes of care. It enables us to measure care quality in terms of safety and outcomes for patients that really matter to patients. We know that outpatient care, which makes up an enormous volume of the activity in the NHS, is actually infrequently captured in part of audit programs. Most of the national audit programs focus on inpatient care, like the hip fracture or the osteoporosis audits, the emergency laparotomy audits. The capture of outcomes related to outpatient care is relatively infrequent, and that's why the National Early Arthritis Audit is a real beacon of looking at how we can measure and monitor care in the outpatient setting. And in rheumatology, we are ideally placed to be measuring and monitoring outcomes and care quality because we have some fantastic guidelines to work from. On the screen here, you've got the European and American international guidelines on how we should manage new presentations of people with early inflammatory arthritis like rheumatoid. And so there is a robust evidence base that underpins these guidelines. The challenge is actually how do we measure that and how do we ensure that we are adhering to these guidelines and getting people into treatment, getting people onto the right treatment first time. Now, I know that in the pressures of an NHS infrastructure, we have finite resource and we have finite time. And as clinicians, the pressure on us to see patients and see the volume of patients based on waiting lists we have post the pandemic is challenging. But actually, it is essential we do it. If we really believe in the importance of the care that we're delivering, we have to monitor it, ensure that we are using the time wisely. That doesn't necessarily mean that the clinician sitting with a patient should be filling in an audit form, though, in real time. And it's a real plea that for rheumatology services, that audit departments provide support to the clinical teams, because in a short consultation, it is very difficult to find the time to both diagnose someone and educate them about a condition and educate them about the need to start new medication, potentially lifelong, and then also complete audit paperwork. So actually doing this doesn't have to be done in the clinic. It can be done asynchronously. But it is essential from an accountability perspective that we measure and record how we do in terms of quality metrics, how quickly we see people, how quickly we treat people, and what their outcomes are. And that allows us to benchmark our performance at a trust or hospital level to our peer hospitals within our ICB, but also regionally and across the country. And that ability to look at our performance and say, how does it compare to our other comparator services, allows us to see where there is scope for improvement. If we're falling far below where our peer services are, that's the key justification to say we need to look at resource allocation. If we have problems with deviation from pathways, it allows us to look and say, what is the evidence-based practice that we're following locally? And the early arthritis audit, the National Early Inflammatory Arthritis Audit, has been doing this now for many years. We started the first rendition of the audit in about 2014. It ran for a few years and then had a substantial upgrade with changing exactly what we're collecting, moving to electronic forms. That was in 2018. The current sort of iteration of the audit, which has just changed from April this year, is building on 5 years of data collection, notwithstanding interruption due to the pandemic. And we've made some significant changes that I think are going to make the audit more powerful and also simplify it in terms of the data that is collected, reducing the burden on sites to collect the data. And also by changing the forms, we've also made it more accessible such that someone who is working in an audit department, not necessarily a clinician, is able to collect the data and enter it. And if you're working in a hospital where you have electronic records, in a setting, the data we're collecting should be easily extractable from an electronic care record. There are things that have changed though. So although we have made the forms shorter, we have also reduced some of the diagnostic indications for that we're recruiting. We have added some as well, and I'm going to go through that now. Perhaps the most important thing to say though is there is a very much updated audit website. And the revised audit website is hopefully going to make it much clearer for you how you navigate it, how you can look at your trackers to look at performance over time. It allows you to break down your performance tracking by site, by different patient characteristics, by diagnoses, and I'll come back to that in a moment. So what are the practical changes? Well, the first thing is we are changing the inclusion and exclusion criteria. So we have now expanded the inclusion criteria to include all new inflammatory diagnoses, and these are shown on the list here. So we include early inflammatory arthritis, that's rheumatoid, psoriatic arthritis, and axial spondyloarthritis, that includes ankylosing spondylitis. The connective tissue diseases, so CTD is a connective tissue diseases, which collectively includes conditions such as lupus, or SLE, Sjögren's syndrome, systemic sclerosis, that's SSCL, myositis, and a group term of undifferentiated connective tissue disease, UCTD. And then also the vasculitis groupings, which include giant cell arthritis, or GCA, large vessel vasculitis other than GCA, for example, Pachiasis, anchor-associated vasculitis, which includes a couple of diseases, granulomatosis with polyangiitis and eosinophilic granulomatosis with polyangiitis, other vascular disease that are anchor negative, and then also a rare condition called Behçet syndrome. These are now the new diagnostic categories. So the previous audit only looked at that left-hand box. As of April this year, you can collect data on the middle and the right-hand cluster or collection of conditions as well. Now, at the moment, we're in a pilot phase that we're asking sites to look at the platform to see how it's entering. We are not yet mandating collection across all these domains, and that will start in the coming months. So please watch out for the newsletters, because we will let you know when we expect data collection on all these. However, if you want to get ahead of the game, you can start collecting information on all of these diseases immediately. What have we removed? Well, in the previous run of the audit, up until April this year, we were asking people to record data on all patients who were referred to an early arthritis pathway, irrespective of their final diagnosis. So if someone was referred in with suspected early arthritis, but ultimately diagnosed with gout or osteoarthritis, those people, we still asked you to return information on how long it took for them to go from the GP referral to their first appointment to a diagnosis. We are now removing the requirement to collect any information on those people with suspected inflammatory arthritis, but who ultimately have a different diagnosis. The implication of that is, in the audit data to date, about 60% or 2/3 of the patients who were entered into the audit had a suspected diagnosis, but ultimately were diagnosed with a non-inflammatory condition. Those patients are now no longer needing to be entered into the system. That should reduce data collection by approximately 2/3 for most units. However, the expansion of the other inflammatory diagnoses will replace some of that activity, although based upon the available data, it is far fewer. So the number of new cases of GCA or lupus in any given week is actually much, much smaller than the number of new cases of suspected EIA. So overall, we believe this is a substantial reduction in the data collection burden. One thing I would say is, in addition to what we have changed with the diagnostic indications, we have also changed the follow-up data. So we are only asking for follow-up data on people with rheumatoid arthritis. And for those patients who have the diagnosis of rheumatoid arthritis, we're also collecting information on how long it takes them to start on treatment and their disease severity markers when they are diagnosed, and again at 3 months. We have removed the requirement to submit any 12-month data. We are collecting patient-reported outcomes, and this is being asked for all patients irrespective of their diagnosis. And the patient-reported outcomes we're going to collect have again reduced in volume. So we're asking patients, those who are willing to return patient-reported outcome, to return information on disease impact using the MSKHQ questionnaire, information on the mental health impact of their disease, and also information on their work impact. And those questionnaires, they were included in the old audit. They have removed the health assessment questionnaire, which is a questionnaire measuring disability, and that was based upon feedback from our patient panel group, who felt it didn't have sort of face validity to the patients who are being recruited. The patient-reported outcomes are essential to complement what we capture on disease metrics, time to diagnosis, and for rheumatoid, time to treatment, and the clinically recorded disease improvement measures. Some of you will think, well, hold on a minute, what is this mapping to in terms of quality standards? And so the first key response to that is that this is about quality improvement, not just audit against a nice standard. When the Health Quality Improvement Partnership retendered the audit, they expanded the scope of the audit to say that we want you to look at other diseases, recognizing we see variation and that outpatient data are hard to get a handle on because we don't code outpatient clinical activity. If we did, then we could collect most of this information programmatically without requiring additional data collection, but that isn't available at the moment. And so if we want to try and benchmark care, we need to try and measure care in outpatient settings in a more granular manner. And GIRFT, and we've worked closely with GIRFT over a number of years, and they have highlighted, and actually there's a number of people who've highlighted that the audit created this slightly perverse incentive that we were prioritizing how quickly we saw cases of early inflammatory arthritis over, for example, giant cell arthritis or vasculitis cases, which from a clinical perspective actually have a higher urgency in terms of need to see someone to start quickly to prevent organ damage. And so the hope is that the move for this new audit and the new scope is that it is going to take away some of those perverse incentives, allow us to benchmark how long it is taking people to be seen with diagnoses like connective tissue diseases or vasculitis. And I suspect initially it will be primarily to look at it at regional or ICB level, but ultimately we hope to move to a mechanism whereby we're collecting information on diagnostic delay, and in the future through linkage, rather than direct clinical data entry, through linkage with NHS digital resources. For example, how many people with GCA have a stroke within 12 months? How many people with an ankylosing require renal replacement therapy or have hospitalization or die within 12 months? So we'll be able to start, as we move forward and collect data over time, to be able to identify quality metrics on some other but really important rarer rheumatic diseases. I'm going to stop there, and we had quite a few questions come through, and we've got a chance now to look at some of these questions. And Ed, I think you are going to rejoin me and we will have a look at these together.
That's right. Thanks very much. So a few questions just on some of the changes that you made or you've outlined there. And I guess, first of all, the first thing to ask about is perhaps for some of the follow-up for the EIA diagnoses. The follow-up cohort's expanded to include PSA and an AXPAR, but the baseline and 3-month follow-up don't necessarily appear relevant to these conditions. So could you explain how the BSR will utilize that information?
So that's a really good point. So I should clarify, for PSA and AXPAR, we only ask for follow-up data if they have a rheumatoid pattern of disease. So we clarify this in the instructions and in the FAQ section on the website. But essentially, we are looking for people who meet the criteria for an early inflammatory arthritis with peripheral joint disease who require the initiation of a DMARD and escalation on an EIA pathway. And so this is really a clinician judgment. If a clinician it doesn't feel that escalation of a DMARD via that type of approach is appropriate, they only need the baseline, that initial diagnosis and delay to diagnosis, but they don't need to collect the follow-up. So, for example, if a patient with PSA presents with monoarticular disease and whom the clinician thinks I'm going to manage this with a local steroid injection initially, and I'm not going to start them on a DMARD, they would be enrolled in the audit. They will have a diagnosis, and then you can track the delay in diagnosis, but you don't need to enter them into the follow-up pathway. So under the checkbox, is this patient eligible for EIA follow-up? That would be a no. And actually, that could also be true for someone with rheumatoid. For example, if you saw someone who is strongly CCP positive with arthralgia, but in whom there is no objective synovitis, so although in your mind you may think this is pre-rheumatoid or this is what we might call clinically suspect arthralgia, they would tick under their diagnosis of rheumatoid, but they don't get enrolled into the audit because you're not starting them on the DMARD.
Okay, that's very helpful, thank you. And a little bit more on PROMs, perhaps. So what PROMs can we expect that our patients will be sent now that the recruited conditions are expanding?
But all conditions will receive the same PROMs. The mechanism for recruiting people into the PROMs component is that their email address is entered into the platform, and the patient will then receive an email inviting them to participate. If they agree to participate through that, they will then be sent a PROM at 0, 3, 6, 9, and 12 months after that initial diagnosis. And they will all receive the same PROMs irrespective of diagnosis. The PROMs we've chosen include the MSKHQ, which is 14 questions and then a single Likert scale capturing exercise activity over the last week. The questions assess a range of domains around the impact of musculoskeletal diseases, but importantly, the questionnaire has been validated across multiple musculoskeletal indications. So it gives you a broad assessment of the disease impact, but it's agnostic of the underlying diagnosis. I think it's really important that we recognise the other impacts of disease, and the other two domains we're collecting the PROMs include mental health and work, again, which are agnostic of diagnosis.
Great, that's very useful. So we'll still include emails for our CTD and vasculitis patients as we always did, and they will get the same PROMs. Thank you. We know that over time, the NICE guidance against which we hope to audit and compare practice has changed, and there was an update in 2020. So can I clarify, will outlier identification move to time to treatment as opposed to time to assessment as per the changes to the NICE guidance in 2020?
So at present, the outlier assessment is remaining constant, where we are looking at the time to diagnosis as the primary metric for which we assess outliers. It will definitely change as a metric because we're no longer going to be including the suspected cases within the calculation of that metric. At the moment, we haven't changed the primary metric, but of course the NICE guidance have changed, and we will continue to review and update the audit standards as in line with contemporary guidance. So I imagine there'll be continued conversations around the role and relative weighting of how we assess NICE quality statement information using the audit data. But at the moment, what is currently reported to the CQC is still time from referral to diagnosis. We also do report on time from referral to treatment as a separate measure. The CQC will receive information on both.
Okay, thank you. Looking at the sort of current and updated list of diagnoses, there are a couple of diagnoses that jump out as not being included on that list, and one of which would be, for example, an enteropathic associated arthritis, and perhaps the other one that might spring to people's mind is gout. Would you mind just sort of explaining why those two diagnoses might not be in the list?
Yeah, so very fair questions. We cannot have an exhaustive list. There will always be some conditions that we can't name, and so there is a category other where people can put in other diagnoses, and for the inflammatory diseases that is very appropriate to use other, although and that may be where the enteropathic arthritis fits in. However, and we do provide in the FAQs the exhaustive list of conditions. Gout is not included there, and that was a decision because we felt that gout was primarily managed in primary care, and that the indications for referral to gout secondary care were often refractory disease. So it's not a delay in diagnosis, but it's about management of refractory disease, which we think wasn't within the remit of a time to diagnosis audit.
And if I'm trying to appraise and analyse the performance of my rheumatology unit, and I'm looking to get that NEIAA data from the website, how do I go about downloading that? I can't initially see a way to do that on the website. Is that possible?
Yeah, so let me just try a different screen share, and I'll just see if I can talk you through how that would work. So if you just bear with me a moment. So if you log into the audit website and you see a page that looks like this, and you go up to the top panel and go down to the clinical control panel. Under here, if you click on export trust data, when you come to this website, you will then see and this will only allow you to see your trust. You'll be able to then download a report list from this. And let me, I'm just going to show you how that works. If I go to here, I'm logged in here, for example, for my trust at King's College Hospital. I can select, first of all, the export keys, which will help me understand what the variables that I'll be downloading will mean. Then I can select a data set. I'd probably want to go to the anonymous data set, which will include all the patient level data for the metrics that are being measured. I can define within the report list a date range, so I could choose what dates to and from I want to download for, and then I download that report. In addition to that, I may also want to download a second dataset, which is the NHS number dataset. It's important to remember when you download these, you need to be ensured that you're within a trust environment, because you'll be downloading patient information to the desktop or to whatever you set as your download site, and you need to be compliant with GDPR. Once you have downloaded those two data sets, you can then open those up, and also in the website there is an audit tool which allows you to link those two, so you'll be able to look at information by patient and track it back to your hospital's ID number, and then you'll be able to look at, for each individual patient, how long it's taken them to be seen, for the rheumatoid arthritis cases, how long it's taken for treatment, and then also whether or not they have met the required standards. That is an Excel spreadsheet that you can download, you can edit yourself and use as you choose. We're always looking for suggestions as to how we can make this more effective. So if you have an idea about something we could do that would make it a better tool, by all means get in touch and let us know.
Thank you very much. Very useful to know we can sort of drill down into that granular patient detail and work out how and why people aren't necessarily meeting quality standards. So that's very helpful. And finally, will this recording and presentation be available afterwards or emailed out for access later and dissemination more widely?
Yes, we will make this recording available, and so people can watch it repeatedly if they so wished.